Chief Instructor Dr. JAYANTO to discuss his experience on subretinal PVR changes.
And it's an honor because these are doyens with whom I am presenting this course. So irrespective, thank you so much for for staying on. So subretinal PVR, as we all know, this is a very funny slide. It says, unfortunately, I have no financial interest in any of the products. This is mandatory slides. In Thessaloniki, we are training that I go to often. Professor Athanasius wants us to present this as a second slide and use the word unfortunately in case one doesn't have any financial interest. So anyway, basic principles of surgical treatment of detachments complicated PVR are those of detachment surgery in general. That is the closure and sealing of all retinal breaks and the complete and thorough release of periretinal traction. Peri means both epi, intra you can't release, and subretinal. So to these can be added the mirage of prevention of recurrence of the proliferative process and its ensuing tractional forces, which, as I said, remains a mirage. Subretinal membranes, also known as retroretinal bands or membranes, are a well-recognized complication of detachments and trauma, and as such are a part of the spectrum of the whole PVR spectrum. In this process, pathophysiologically, RPE cells migrate from the normal monolayer into the subretinal space, undergo metaplasia into macrophages and myofibroblast-like cells that proliferate as sheets or bands. If they proliferate as sheets, these are diffuse sheets which lack collagen usually because they compose of glial cells. They don't contract much and they don't prevent as such retinal detachments in general. But if they form bands, they contain myofibroblast and they form an annular configuration which raise the neuroretina and impede attachments. These bands require division or removal. Morphologically, they can be subclassified into annular strands, linear strands, and moth-eaten appearance sheets, as is depicted here pictorially. The slide on the bottom right sometimes confuse you as a epiretinal fixed fold, but they contain, so one has to be very careful, one has to examine it under zoom and use DDMS, and before trying even to peel the epiretinal bands, there exists no epiretinal membrane but a subretinal membrane contracting from below. So one has to be very careful. I just wanted to highlight this picture because this is a confusing thing, because one can tear the retina apart in the absence of any epiretinal membrane. You are going for an invisible ERM. Good to stain in these circumstances to be on the sure sides. Clinical key points are that bands have to be removed, but even bands do not always prevent reattachments. So one very good sign, a test thing is to put PFCL after you have released all your epiretinal traction and see whether those subretinal bands need to be removed or not by using PFCL, perfluorocarbon. When removing subretinal bands, it is important to select a location that maximizes access and leverage on the band. That is where the band is thickest, you identify. Never use diathermy over a band to create a retinotomy, as this can sever the band. There is several techniques are being described: spaghetti maneuver unimanually, or bimanual with a pick and a forceps, or with two forceps with a hand over hand technique, as I will show in the video. Principle is to maintain a wide angle system. Do it in a wide angle system. So you are visualizing what the remote peripheral effects of your localized peeling is doing. Because if you are not careful, you can create iatrogenic complications if you are not careful of the remote effects of your localized actions. For that, a wide angle system is necessary. Never lose access by breaking the band, because tensile forces will cause the band to retract if you are doing it unimanually. Using a localized retinotomy. Sometimes, if you see the morphology of the bands, you have to take recourse to extensive retinotomy so that you have access to bands. And I will also describe a peculiar situation where extensive retinotomy is actually ideally required. So there has been a paradigm shift over the years, and I want to introduce the concept. Many people are aware of this concept. Dr. Cyrus had simultaneously more or less coined this term as tug of war for epiretinal and subretinal membrane peeling. So I also call it a tug of war concept. by using either spatula forceps combination or two forceps combination, and DDMS and flexi loop in various combinations. You can of course use the PFO to provide contraction. These are the pictorial depiction. I won't go. Last word before the video is ab externo subretinal PVR removal. I remember Rupo Kanti is a great advocate, my good friend, of ab externo PVR extraction. So it reduces, I haven't tried much, I'm still learning the process, but reduces the number of operations needed, avoids the visual impairment caused by multiple surgeries, they say, the advocates of ab externo. But patients with extreme PVR, significant epiretinal membrane contractions, prominent retinal shortenings, and especially shallow detachments, these should be avoided. People do both ways, but I feel technically membrane removal, ab externo, and then vitrectomy is preferable. Area of highest detachment is identified, and trocar is advanced at a 15-degree angle to pierce the retinal choroid in this area, and then cannula is visualized to be placed in the subretinal space, and forceps are advanced to access the subretinal bands. The band is then grasped and pulled out of the eye. Be very careful. Retinal injury and subretinal bleeding is often possible in these situations. And as I repeated again and again, the study, the macular, if the bands are extensive bands approaching the macula, encroaching the macular area, best, because these are often attached to the neurosensory area more than to the RPE. So you have to see it visually, as I will show in the video, even submacular bands to detach them very carefully so as not to injure the neurosensory retina more. So when bands stopping short of the submacular bands, you use the ab externo. These are the pictorially these techniques ab externo. The light is, the forceps is introduced, and a chandelier illumination is there, and through a trocar cannula, you are just ab externo. From the scleral side, you are removing the band. We go to the video straight away. Localized, I am not a great fan of doing posterior retinotomy, posterior to the equator and removing the bands. If it is anterior to the equator or near about the equator, yes, I am okay with it, as is these cases. But posterior retinotomy, as Sangeet would agree, PVR, inevitable. So these are the cases where there was extensive areas of attachment of the bands. So bimanually they are being removed after an extensive retinotomy. Much easier to go right, even required up to the disc area, and under direct visualization, you very carefully dissect these tissues so as to cause least injury to the neurosensory retina, which is the most important area to be preserved in such cases for your postoperative vision functional recovery. You use a various combinations of ILM peeling forceps, end grasping forceps with two hands. Sometimes these bands are just beyond the retinectomy, so as in this case. So you use a tug of war method, tangential. The principle is to keep it tangential, not to use the other vectors in the other directions, 90 degree, tangential to the retina. Be tangential retina, move your forceps till you feel comfortable. Sometimes you use a DDMS to release the folds after releasing the membranes. That's the end result after the extensive membrane peeling is done. The next case, again extensive. The last case, I would combine. Here I am using a spatula initially and then two forceps. The last case, it was a multiple surgeries elsewhere, huge macular hole, more than 2000 microns. I had combined a retina transplant along with that, as you would see. So you can see, you can go right up to the macula and very safely peel those membranes under direct visualization, causing least injury. But I will definitely try out the ab externo in future with restricted indications. So use a hand over hand technique sometimes, use it tangentially, but essentially it's a tug of war technique. It's a tug of war going on to release these membranes. Very short video. So in another area you start, because these were all extensive membranes. So you finish one quadrant, go on to the other quadrants until the whole. Sometimes you have to go on putting PFCL, reattach the retina. Here the last case, combined with retina transplant, multiple surgeries elsewhere, I think 5 to 6 times, and we release the membranes. The retina was already foreshortened, as you can see, those diathermy laser, previously lasered areas, where I had to again redo the retinectomy in those areas. Sorry for the sound. And we are putting a retina transplant here from California. And the last, just few more seconds, last few seconds, 2-3 seconds. Foreign body and with a subretinal membrane. After removal of the foreign body, here there was a pre-existing tear through which the foreign body went in. You just remove the membrane through that retinectomy and complete the case. Thank you so much for your kind attention.